Next we have Dr. Aditi Grewal, and she's going to speak on Frontalis advancement flap. Can this procedure replace Frontalis sling? Yes, it is.
Good morning, everyone. There are no financial disclosures. So we all know that surgical repair of severe congenital ptosis are often challenging as levator strengthening is not sufficient, and we have to utilize the frontalis muscle. Conventionally, using the fascia lata or silicone sling, we bypass the LPS and suspend the frontalis onto the tarsus. However, of late, a technique has gained more traction, and that is the frontalis muscle advancement flap, which is directly sutured to the tarsus with or without a levator pulley. So if we look at the background, sling has been described first in 1880, and it is quite popular. It's a workhorse procedure. However, there's a risk of infection, granuloma, and recurrence of ptosis. And there's an inherent static nature due to the nature of the material, whether it's fascia lata or silicone. This produces a lid lag in downgaze and significant lag of thalamus. In addition, children may require multiple procedures over their lifetime as they outgrow. The frontalis flap is not actually new. It's been described since 1900s, where Fergus anecdotally described this incision using an eyebrow approach. However, this technique is not standardized, and of late in the past decade, because of popularity in the Asian population, it's been regaining traction. So we designed a study to evaluate whether this is going to be effective, what is its efficacy, how does it compare with the conventional silicone sling, and what are the complications with this technique. This is a non-randomized prospective study with treatment-naive patients of severe congenital ptosis, which was uncomplicated. They were either underwent the silicone sling using the Orolab sling or the frontalis muscle advancement flap. The recruitment period was from July to January 2023, and the follow-up was minimum of 6 months. Baseline MRD1 amount of ptosis was noted, and the final outcome comparison was MRD1, lid lag, lag of thalamus, complications, and subjective response. So for the sling, we used the Fox pentagon technique with an Orolab sling. And for the frontalis muscle advancement flap, I have a diagrammatic representation. So we use a central and a lateral suture to advance the frontalis muscle onto the tarsus. We went through, and this is a short surgical video, we went through the eyelid crease incision, after which the frontalis muscle was isolated by dissecting in the suborbicularis plane bluntly. The dissection was done with the help of artery forceps, and the frontalis muscle was not separated from the lateral attachments. It was just advanced forward. The puckering from the skin was removed again with blunt dissection. Once the frontalis flap was identified, it was checked by tugging it and seeing the movement on the forehead. This was then advanced and sutured onto the tarsus by incorporating a subvitrinal bite of the levator muscle, thus effectively producing a combined levator plication as well. Only 2 sutures, central and lateral, were applied. The lateral was higher than the central suture, and then the lid crease was closed with crease-forming sutures. So coming to the results, the baseline characteristics were comparable with an MRD comparable, although the silicone sling had a greater amount of ptosis as compared to the flap group. At 1 month, the sling seemed to be doing better, but at 6 months, the MRD1 was comparable in both the groups. Lid lag was present in all patients in the sling, but only in 87% in the flap, as well as the amount of lag of thalamus was much less in the frontalis flap group, although this was not statistically significant. So if we look at this, the MRD improves in both the groups, and at 6 months is comparable. In addition, the first panel is a silicone sling, where we can see a good cosmetic outcome. Also in the frontalis flap done in the right eye, at 6 months, the outcome is quite successful. The lid lag was there in all cases in the sling group, as well as in the frontalis flap, it was there only in 87%, and it was mostly mild or moderate. Coming to lag of thalamus, in some patients in the frontalis flap, there was actually no lag of thalamus at 6 months, which was an important finding. There was additionally a finding of recruitment of frontalis. So this patient underwent a frontalis flap, and when he's looking straight, the MRD looks a little low, but when he's able to raise his eyebrow and then see, the MRD becomes comparable, thus indicating that the procedure in itself is quite dynamic in nature. So coming to the discussion, frontalis flap has been compared with LPS resection in different populations, and the outcome says that the frontalis flap is actually better than LPSR in severe ptosis. That's because the LPS muscle in itself is quite weak. However, complications like eyelid deformity, entropion are actually quite common. There's an ongoing clinical trial between the frontalis flap and sling in Egypt, but the results are currently awaited. In our study, the MRD trend in both groups showed a significant improvement, and at 6 months, they were comparable. The frontalis flap had a more consistent outcome at 1 and 6 months. These are some of the findings that the flap allows for a greater dynamicity. The scars are completely hidden, and this particular patient is able to use the frontalis flap by tugging the eyebrow under his turban. So this is a Punjabi effect called the turbinator, and he's able to utilize the dynamic nature of this flap. The limitations are the small sample size, and the both groups are not age matched. This technique is still new, it's a pilot study, and right now it's showing a comparable outcome, but we need a longer study to see its effect. Thank you.
So, what about the lid crease formation? Because
Since we had taken a levator plication bite, we were able to pass the skin, the combined frontalis muscle and the levator bite, and then back out of the skin to give the crease forming sutures.
but in the Sardarji, there was no lid. So, have you repeated the procedure for the lid crease formation?
In flap, so far I have not had to repeat the procedure. There are 2 patients who are not a part of this study who underwent the frontalis flap, and they have an undercorrection, and for them I'm planning the sling. So this technique is still new. One major limitation which now the latest literature says is that in the frontalis flap do an overcorrection of almost 2 millimeters above the limbus. I did not attempt that. I was afraid of risking a corneal exposure. But maybe in future cases with patient consent, I can probably try an overcorrection and see whether it's this
So
truly can
does the
replace this.
literature say that has there been any need of doing a sling after frontalis flap in
Ma'am,
patient?
if it doesn't, because ptosis is a very visible cosmetic outcome.
Yeah.
So if the patient is not happy with the flap, I am not keen on revising the flap again.
That's-
So I'd rather do a procedure which is more time tried and tested if my new
And
procedure
is there any relation with the pre-op frontalis action of the patient
we
and
have-
the results?
So there are, we have like the facial nerve stimulation test. We do have electrodes to test the frontalis muscle. I have not done that in my study so far.
Clinically, if you see the...
Yes, clinically we can identify if the frontalis recruitment is there. There is one point for this, that when they say that when the ptosis is corrected, in severe ptosis, once you have opened the eyelid and your MRD1 is above 1 millimeter now, the stimulus, the Herring's law stimulus of trying to use the frontalis goes down. So even after sling, Dr. Roshmi has previously described that even after doing a sling surgery, the patient refuses to use the frontalis anymore because the eye is open.
Eyes.
So in that situation, how to retrain them to continue to use a dynamic flap, that is something under.
And how much length of frontalis do you pull out? Any demarcation for
So
amount of closing?
I don't do the lateral incisions. I don't try and make a measured flap. I tug onto it until it comes comfortably onto the tarsus without causing any puckering on the skin. So the idea is to have a very good release in the supraorbicularis plane from subcutaneous while going above the eyebrow rim, and that's done with a blunt dissection. We can't go too medially because of the supratrochlear vessels over there, so we have to be careful, and easy traction so that it comes all the way to the tarsus without causing any puckering.
How would they height, brow height in both the cases?
So there was no lowering of the eyebrow. In fact, preoperatively, I didn't include in the assessment, but preoperatively the patient with severe ptosis had a higher brow height because of the constant
So
recruitment.
that is also one point in the symmetry part of
Definitely,
it.
in the future I
Brow
will.
symmetry.
It
Thank
needs lot of work, Abhi.
It is- it
We
is-
all are seeing, I've also tried one, Abhi nahi maza aa raha, but it needs lot of work and we need some precision.
Surgical synesthesia is required for all these things.
But definitely that lid lag and sling ke jo scars hai, usse it gives very good relief to the
Dr.
patient.
Aparna?